Welcome to ACAP Guilford's monthly meeting. We're so glad to have you join us today. Are you familiar with what ACAP is and what we do? Let me tell you very briefly. ACAP Community is an educational 501c3 nonprofit organization that offers information, resources, support, and community to those of us who are caring for aging parents. As you can tell from our name, our focus is on supporting adults as they care for their older, aging parents. However, all caregivers are welcome, whether you're an adult child, a friend, another relative, or a professional. Each of our 9 ACAP chapters, which are located all across the Eastern Seaboard, offers monthly programs that address issues related to aging, family dynamics, and adult-child caregiving. Presenters are experts on the topics they address, and many are or have been caregivers for their own parents or in-laws. ACAP Guilford meets on the third Thursday of every month. You may have noticed that we have moved from an evening meeting to a lunch meeting. Our meetings will begin at 11:30 with a light lunch and a chance to speak with others who are caring for their aging parents, followed by a program about an important topic, and that will begin at noon every month. We'll provide the lunch, but please do register online so that we have enough food for everybody. Our meetings take place at Senior Resources of Guilford at 1401 Benjamin Parkway in Greensboro. Folks who simply can't participate in person can view our programs at noon on our Facebook page and the ACAP community website. You can also watch past programs from all of our chapters on our YouTube channel. Give us a couple of days and we will post this so you can review it. See it again. We would like to thank our sponsor for today's program, the always supported Providence Place Senior Health and Housing. Let's welcome Robin Thompson, the Community Sales and Marketing Liaison, to tell you a bit about their community.
Thank you, Cheryl. My name is Robin Thompson, and I am the Sales and Marketing Liaison at Providence Place Senior Health and Housing in High Point. If you don't know where that's at, that's on Westchester Drive in High Point, where the old Westchester Mall used to be years ago. We have independent living with month-to-month rental. It's not a buy-in. We're not a buy-in community. Also have nursing and rehab, long-term care, and short-term rehab with in-house rehabilitation. We also have assisted living. That would be our Westchester Harbor. We're a 90-bed facility with a secured memory care unit. We also have a secured memory care unit in our nursing facility as well. We also have around 7 to 8 cottages on our property. A lot of people don't know that we have that, but we do have that. And in our cottages and in our independent living, the monthly rent includes everything except for your phone. We're kind of tucked back in the back beside of on Whittier Avenue, beside Hospice of the Piedmont. So if you need more information, please contact me. I think we have a little banner there on the screen, so be sure to reach out. Thank you very much.
Thank you again to Providence Place and to Robin Thompson for their ongoing support of ACAP. Now let's turn to our program. We would like to hear from you, so if you have questions or comments, please just speak up if you're in the room or write in chat if you are live streaming. You know, we are sometimes concerned because we see that our loved ones seem out of sorts, unusually sad, or very concerned. We use words like depression and anxiety, but we have questions. What does this mean? And what can we do? We are fortunate to have Dr. Beverly Jones to share his answers based on years of training and experience. Dr. Jones studied psychology at Duke University and attended medical school at UNC Chapel Hill. Dr. Jones completed 5 years of training in geriatric psychiatry at Johns Hopkins Hospital before joining the faculty at Wake Forest University School of Medicine in 1993. Since 2003, he's been in private practice in Winston-Salem, North Carolina. Dr. Jones' areas of expertise include the diagnosis and treatment of memory disorders and Alzheimer's disease, and the recognition and treatment of depression in the elderly. Dr. Jones, welcome.
Thank you. There's an ACAP chapter in Winston-Salem, and I've enjoyed attending and taking part in that organization. It's really a great organization, and meets a set of needs that I think are not often met with some of the other support groups. So this will really just be a short discussion for me, and then I really want to have questions from each of you that you might have regarding depression and anxiety. There's a handout you have that should say Cognitive and Mental Health and Aging. And this came off the website for the National Institute of Mental Health, just giving us some bullet points, so to speak, about the issues of aging and mental health. One of the biggest changes and one of the biggest concerns as well as fears is memory loss, cognitive loss, and confusion in aging. And they point out that for most older adults, age-associated changes in cognition or thinking are mild and typically don't interfere with day-to-day activities. Older adults are capable of learning new skills late in life, but it often takes people longer to learn things. I mean, I've seen this in myself. Short-term memory loss will slow down with aging, but often long-term memory declines less than short-term memory loss. Now, there's some changes that we consider normal as people get older. Reaction times physically are slower. Problem-solving abilities may be somewhat reduced. And the speed with which we get information in our brain and also retrieve information slows down. And that's why you might see somebody you recognize, you know who they are, you can't quite come up with their name, and then a few minutes later or half an hour later it comes. But that tells you that the information is in there, it's just taking you longer to retrieve it. Same kind of thing with finding words. I was trying to refer a patient to another doctor that I worked with for 20 years, and it took me about 10 seconds to come up with her name. These are things that happen really normally with aging, and typically they're not too much to worry about. Aging experts point out that wisdom and creativity often continue late in life. So it can be a time where you can branch out into other activities, or you can develop hobbies, interests, or special abilities that you've had earlier in life. Personality tends to remain stable over time. If you're outgoing in young adulthood, you tend to be so in later life. Now, this can work both ways. If you tend to be a worrier or tend to be somewhat preoccupied with what might happen, that can carry on throughout your life and be a challenge at times. In general, if patients or people are in good physical health, they typically have lower mental health problems than younger people. But there are cases of depression, anxiety, even schizophrenia, and certainly dementia. Increasingly, older adults do face challenges with regard to substance use disorders or substance abuse. I do some weekend coverage in hospitals outside of Raleigh, but also outside of Asheville. And it regularly surprises me how many patients in their 60s, 70s, and even 80s sometimes are using drugs like cocaine or methamphetamine. So these are very common problems, unfortunately, throughout the lifespan. Now, dementia is one of the biggest concerns people have. Alzheimer's would be the most common type. We don't consider that to be a normal part of aging. Now, what we mean by that is you can age successfully without getting dementia, and many people do. However, with regard to Alzheimer's, the biggest risk factor is aging. So it's a little counterintuitive there. The incidence of aging or the prevalence of dementia in a group of 65-year-olds is only about 1%. But if you look at a group of 75-year-olds, that goes up to about 1 out of 10 people. And then if you look at 85-year-olds, some people say 1 in 3, or maybe 40% of people, if you sit them down and test them, would have evidence of likely dementia. So dementia clearly rises with aging, but it doesn't mean everybody's going to get it. And so what researchers are trying to understand is, how do we keep ourselves healthy cognitively? How do we stay in the group that preserves function and preserves memory? There has been no simple pill. There has been no simple supplement. There's no simple pharmaceutical solution to this at the present time. The Alzheimer's Association and the other aging support agencies summarize this to patients and say you should stay socially active, mentally active, and physically active. So staying active is good for your brain. That's very important to remember. Now, physically, there are changes, of course, with aging. About 90% of older patients have at least one health condition that's chronic. About 3/4 have 2 or more. And of course, the most important conditions would be heart disease, cancer, stroke, or diabetes. They account for about 2/3 of the causes of death in people over 65. Interestingly, people over 55 account for about 1/4 of Americans diagnosed with HIV infection. Hearing impairment is a big issue. It is widespread. About 25% of people over 65, but younger than 75, have hearing loss. And then when you get over 75, about half the population, up to 50%, have hearing loss. Now, this is increasingly important because researchers have shown that hearing loss is a risk factor for getting dementia later. So if you have hearing loss, it's important to pay attention to that, get an evaluation, and try to address that. The exact mechanism for that is not clear. It could be that people are withdrawing socially because they can't hear and can't participate as much. That's very likely. And then there are also some thoughts that when the ears are not properly stimulating the brain, then the brain cells start to shut down or even atrophy, which is shrinkage. So without the normal stimulation of your vision, your ears, your senses, the brain undergoes changes. So it's another reason to, as much as possible, stay active and keep using your brain. And if you have hearing loss, try to find ways to address that. You know, in the past year, hearing aids have become available without a prescription. And so the options for hearing loss have really expanded and become more affordable and more available to people. And so it's certainly worth a try. For years, I've used a very simple amplifier with earphones for patients in the office, and something for $25 often gives them enough volume and amplification that they can start hearing and have a conversation. Again, what can you do to make healthy aging a reality? The first thing on the list is exercise, and that doesn't have to be jumping jacks or a mile run or getting a sweat for an hour. Moderate exercise can help you stay active physically and help improve your mood and, of course, help your brain. Make adjustments for losses in your senses, for example, glasses that are appropriate and work properly, hearing loss. If you need assistance to prevent a fall using a cane or a walker, many people are hesitant to do this, but the alternative is they often stop walking and ambulating as much. And there's a term we use in medicine called deconditioning. It basically just means you get weaker. And if you're in the hospital, in a hospital bed because you've got pneumonia, let's say, the experts will say that within a matter of days, your muscle mass starts declining and your strength starts declining. So that's called deconditioning. So imagine what happens if somebody breaks a bone, breaks a hip, has knee replacement, goes home, and then lays in bed for 2 or 3 weeks. Well, they've lost function during that time, and then when they do try to get up and start moving, it's much harder. So doing everything you can to maintain activity and maintain mobility in a way that's safe is very important. Certainly, if you're anxious or depressed, we don't recommend using alcohol or drugs to cope with that. Get help from your family doctor. And this last one is very appropriate. It says, be an interesting person. Engage in something that matters to you and that you care passionately about. This is more of a psychological and in many ways a spiritual issue. I see a lot of patients that complain of depression, but a large part of that is really boredom. And they don't, when I talk to them, they don't seem to have anything that's really meaningful in their life. We can give you all the antidepressants we have, but if you don't have some purpose, if you don't have something that's important to you, to what I say, pull you forward, pull you through into the day, give you a reason to get up, the pills are not going to fix that. And so often that comes from relationships, that can be volunteer activity, could be an artistic activity, could be reading for some people. But any activity that is important to you, meaningful to you, and that you're passionate about, it increases your chances of healthy aging. So we're supposed to talk about depression and anxiety, and I'm just going to give you some brief thoughts about depression. The first is that it's an overused and confusing term, because we use the word depression both to refer to a sadness or a low mood that we might have that could be completely understandable in a certain situation. But at the same time, we use it to be a much more severe condition. And at its worst, people can lose touch with reality, become unable to function, stay in bed 24 hours a day, stop eating. It can be life-threatening. So that term covers a very wide ground of severity in terms of the symptoms. So there's a big difference between being down, being sad, and having what they call a clinical or a major depression. The other thing is that when researchers have gone into the community where people live in their own home, living independently, and are in generally good health, the rates of depression are generally low and comparable to younger people. So being older by itself doesn't cause depression. However, when they find people in long-term care settings whose health is failing, whose vision and hearing are failing, whose memory is failing, who have chronic pain from arthritis, well, then the rates of depression go up, and that's somewhat understandable. But again, the positive thing is that if you can manage to stay healthy and stay independent, aging by itself doesn't necessarily cause depression. Now, I put a topic here, a statement that said antidepressant medication, are they underused or overused? And the reason I put that is that in the 80s and 90s, we had the advent for the first time of antidepressants that were easy to use and had very few side effects. Prozac was the first one, and books have been written about this. It was extremely popular. It certainly helped people with depression. Even people who were not severely depressed might take some and say, gee, I feel better than I used to. This is amazing. And so these drugs became extremely popular. Different companies came out with different versions. The Zoloft is one, Paxil is one, and there have probably been dozens since then. Now, fast forward 20 years, 25 years to where we are now, and many people are concerned we've got too many people taking psychiatric medications, too many people taking antidepressants for what really may not be a severe clinical depression. And there's an author, Robert Whitaker, who wrote a book called The Epidemic of Depression. And he argued that around the period of 1990, there were three forces that led to the dramatic increase of prescribing antidepressants. One was the psychiatrists, the academic researchers who wanted to find good treatments for depression. And so when these drugs like Prozac came out, they were very excited to have them. But they also wanted to change psychiatry from being a Freudian type of endeavor where we were talking about the id and the ego and unconscious forces. They wanted to bring that into the mainstream of medicine and say, we're the doctors of the brain, we're treating a chemical imbalance, we're treating a biological problem, we've got white coats and we're just like everybody else in medicine. So there was a bias, many people think, from the doctors and the researchers in medicine to embrace the biological explanation for depression. The second, of course, was big pharma, because it was big business. If you had a great antidepressant drug, you could make millions or not possibly billions of dollars on the market with your medication. So across the field of the pharmaceutical companies, they were all racing to develop whatever they could that would help depression because they were big money makers. And then the third was really the mental health advocacy community, the patients and the supporters who wanted to get away from the idea that having mental illness was a stigma, that having mental illness was a reflection on your moral character, that you were just lazy, that you weren't doing things because you just didn't, have enough fortitude. They wanted to embrace this idea that mental illness was a brain disease and it was biological, and therefore the treatment was medication. So everybody liked this idea that if you were distressed emotionally and you had depression, then you needed a medication. And there's one more reason that became so prominent. Certainly in medicine, the prescribers and the primary care providers were getting less and less time to see patients. And the thought of the old family doctor that knew you as a person, knew your family, could listen to you about your problems for maybe 15 minutes or half an hour, that wasn't possible anymore. You need to get people in and out. And I've seen and heard about patients who, with very understandable problems in their life, they go in to see their doctor, they break down crying, and the doctor wants to give them a medication right away. They could have lost their job, they could have wrecked their car, a daughter might be in jail. They're crying, they're upset about something that's real. That doesn't mean they have a clinical depression. But if you've got a patient crying in front of you and you want to do something, the pressure on the prescriber is to pull out that pad or get on the computer and give an antidepressant. So that's kind of my personal caution about antidepressant medications. There's one more piece of information, and that's that we typically, when these drugs came out, were very excited because we said, well, they treat 2/3. If you have a depression and you take a medication, you've got a 2/3 chance of getting better. Over time, we realized that was an overestimation of their real benefit and efficacy. And so when they also went back and looked at all the clinical trials and did what's called a meta-analysis, they found if you had severe depression, there was no question that antidepressant medication is better than a placebo. But if you have a milder form of depression, if your depression score is only in the teens instead of 25 or 30, interestingly, the drugs didn't work better than the placebo. So that's my concern, is that there are a lot of people in society right now who have milder forms of depression that may even be considered within the normal variant of human experience, but they're being medicated, or even themselves, they're thinking, I shouldn't feel this way, I shouldn't be upset, I shouldn't be depressed, and they're out seeking medication. There are some very good antidepressants out there. I certainly use them every day in my office. I don't mean to discourage or disparage their benefit. I am just kind of issuing a little bit of a caution that not everybody who is upset, sad, or distressed needs to be on medication. Any thoughts or questions about medications for depression?
I have a comment. This is something happened to me recently. I'm usually an upbeat person, outgoing person. Nothing really bothering me. And I think it was last week. I got in this mood, and the first thought was I was depressed, being worried, which normally doesn't happen. And my wife said something to me, and I didn't snap at her or anything like that, but it was my usual self. You know, and I went through the house, I thought about that, what's going on here? And a lot of times when there's something going on, if you don't share or be honest about it, it eats you inside. That's what happened. What happened to me was that over the past 7-8 months, it's death. A lot of people that I have a relationship with, or I was close to, family, friends, and things, and it was just overwhelming to me. I had not realized that though. So, but once I talked with her about what was going on, I'm not at that stage anymore. And I think if I could have eased that gun to someone and that medication you was talking about, they may have given me that medication, but it was no reason to give it to me. Because the cure was that I shared it with her.
That's a very valuable message. A lot of times when we're under emotional distress, yes, something has changed, no doubt about it. And yes, it sounds like depression. You're not yourself, you're more down, you're more edgy, you're more irritable. These are real things. But the question is, does that really need a medication? Or would sharing that, coping with that, help you move through that? And in many cases, it will. There are other options for treatment of depression. I'm going to skip over healthy diet and come back to that in a second. The newer treatments are very interesting. One is called transcranial magnetic stimulation. You got people here in Greensboro that are doing that. It's called TMS. And they basically just put a strong, powerful magnet up next to your brain and your head. And they turn this on for about 20 minutes. And you come back every day for about 4 weeks. And it's very clear that in many people, this treats depression much like a medication, but without a lot of the side effects that sometimes medications have. And it's a very easy treatment. It's not painful. You can listen to music, you can read a book, you can watch TV. You do have to stay relatively stable because you want the magnetic field to focus on the frontal part of the brain. But that's been available for about 5 years or more. And I haven't had a lot of patients that have had it, but I had one in particular where she had been chronically depressed, and we tried medications and she was a little bit better, but not really happy. And she underwent this treatment and her depression was eliminated. So there are some individuals for whom this is an extremely effective treatment. And insurance has started to cover this now, so it is an option that's available to many more people. The other new thing that's quite fascinating is ketamine. And this is an anesthetic. It's been out for 30, 40 years. And it's what's called a dissociative anesthetic. It doesn't necessarily knock you out in terms of making you unconscious, but it dissociates your awareness from the experience of pain. It's often very useful in battlefield situations because a medic can give this and not risk putting the person into respiratory depression or over sedation. They'll remain awake, they'll remain breathing, but they'll be dissociated from the pain and they'll be able to sew up a wound or address their needs. So about 20 years ago, I don't know how they did this, but someone started testing ketamine for severe depression. And in particular, the amazing thing was they tried it on people that were acutely suicidal. So these people were very depressed, very hopeless, ready to give up living. And they gave ketamine, and within hours, they were lifted out of this depression and suddenly could think about life and think about the future in a more positive way. So this was really revolutionary. Antidepressants usually take weeks to work. And so they studied it more and more, and gradually the pharmaceutical companies came up with a way to give this to patients in the office. And so they have a nasal spray. It's called Spravato, and it releases the ketamine into your nasal passages. You do have to stay in the office for a few hours because it is an anesthetic and you do have some mental status changes. But this can be given 3 times a week for several weeks and has been very effective for many people where antidepressants are not. Now there are clinics that are also giving it. You can take it as a pill, or sometimes they'll give it intravenously, or some clinics even just give an intramuscular shot as a simple way to give the medication. And so if medications are not working for someone and they're desperate to see improvement and want to try something, ketamine is certainly available and is helpful for many people. Now, insurance companies are, I think, trying to wrap their minds around this and figure out how to reimburse it and what to do about it, but gradually it's becoming more available. Now, I put at the bottom the old standard for severe depression is electroconvulsive therapy, or ECT. And this was discovered in the 1940s, even before a lot of the medications we use were discovered. And this involves the application of electricity to the scalp and the initiation of a seizure, which is simply the brain cells firing all over the brain in unison. I was trained at Duke to give ECT. I worked at Thomasville for over 10 years using this for patients. And for very severe depression, particularly where people have stopped eating, they may think they're dying, they may think they've got a brain tumor, they may think they can't eat because they've got stomach cancer. Their depression is so negative and so overwhelming, ECT can be an extremely helpful treatment. Now, it's probably underutilized because you do have to go to a hospital. It does involve being put to sleep for about 3 to 5 minutes. And then there's a bad image that comes out of Hollywood from the Jack Nicholson movie where he was given ECT really as a punishment. But it's always, when researchers have looked at the data, it's always been more effective than medication. It's just the logistics of it make it a little more challenging. When I did my training at Duke, one of the patients who had come in for a treatment as an outpatient was actually a retired psychiatrist. So it was fascinating to talk to him. He came every 3 months for an ECT treatment. And he said, I take some medication, but I don't think it's the medications that help me. I think it's this ECT every 3 months that keeps me out of depression. So you don't have to be in the throes of severe depression. Many times this is good for moderate depression. It helps keep depression at bay. So if you know of a family member or you hear of someone getting ECT, that can be a very good thing. That's not a bad thing.
Yeah, we have a couple of questions that have come in from our online audience.
Oh, great.
Jennifer asked, are there any medications to avoid, such as black box label warning with dementia?
Well, I assume now you can use antidepressants safely in dementia. A lot of good evidence that they can be a benefit and they're generally safe. The black box warnings are on the medications called antipsychotics. These would be things like risperidone or Seroquel, Abilify, very common. And this is a challenging area of medicine because the behaviors in dementia are really what cause the caregiver burden, much more so than just the memory loss or confusion. So irritability, agitation, aggression, they can really wear down a caregiver, and of course, ultimately, at the worst, even put people at risk of physical harm. So we've tried a lot of different things to treat these things. low-dose antipsychotics, in my experience, like risperidone and Seroquel, in many cases are helpful in reducing irritability, reducing agitation. But they have some risks associated with them, and the FDA put a warning on them. They're not approved for treatment of dementia. So the alternatives would be an antidepressant that is approved and can be used safely in dementia. A lot of times just some Zoloft or sertraline can reduce irritability, can reduce mood swings. And then frequently we try the medications used in seizure patients called anticonvulsants. Depakote would be a common one. Now, the research regarding Depakote has not been that astounding, but it is safe, and for some patients, it does appear to help stabilize mood swings, anger, and so forth. Those are the main things that people think about with dementia-related problems.
One of our other viewers asked, how do you know when you should stop antidepressants?
Well, that's a good question too, and a challenging question. If you've had one episode of significant depression, many people would say if the medications have helped you, then within a year you can think about stopping them. If that depression recurs, or if you look back over your life and you've had 2, 3, or more, certainly more than 3, then the risk is at some point depression is going to come back. And it looks like it is safe to take antidepressants over time, and taking the antidepressants continues to give you some benefit and protection from another episode. So it depends upon how frequently you have depression. The more frequently you have it, the more benefit you get from continuing it. And then the severity, of course. If your depression is so severe that you're out of commission, you can't function with your family, you can't go to work, or become suicidal, you really should stay on the medication.
Is there an increased risk for these treatments, particularly the medications, the other treatments, for folks who are older? Do they work differently and better, or with less risk for younger people than older people?
Well, in general, the risks are about the same. For medications, in general, for depression medications, they're certainly safe to use in older patients. Now, sometimes patients are more sensitive to side effects when they're older, and so that's a consideration. One thing I see, we usually say start low and go slowly with the dose, because the metabolism in older patients can be diminished, so the drug isn't eliminated as quickly. But really, the evidence shows, for example, if you're treating depressed patients, you need to try to get to the same dosage that an adult patient would use, a younger patient would use, to get efficacy. You might take a longer time to do that, but you want to try to get to the same level. Now, certainly drugs for anxiety, sedatives, Xanax, Valium, Ativan, those kind of things, we need to be very cautious in older patients. Many times they can tolerate low doses because anxiety complicating depression can be very painful for people. And it's not just being a little worried. For many people, anxiety is a very, very uncomfortable and really intolerable state to be in. For example, when some people get depressed, they stop functioning, they lay around, they have no motivation. They may even think about suicide, but they're just too tired and apathetic to do anything about it. If you take that patient and add anxiety on top of it, where they're apprehensive, they're worried, they're tense, it almost gnaws at them. And so anxiety becomes a risk factor for suicide. And so I personally believe when you have that level of anxiety, they need these benzodiazepines and need a mild sedative to help them feel better and cope. But you do have to worry about falls, you have to worry about memory loss, you have to worry about confusion, and just be very careful with those medicines.
Thank you.
Yeah.
What would be the like a standard protocol for someone that's been on an antidepressant for years that would want to switch because of side effects of what they've been doing?
Yeah. So there's an issue called the discontinuation syndrome. Other people might call it withdrawal from antidepressants. There's no question if you take a drug that's been boosting up your serotonin level for years, or even sometimes just months, your brain accommodates to that and it's expecting those higher levels of serotonin. And if you suddenly take it away, then serotonin level drops, your brain goes, hey, what's going on here? And you can get very anxious, you can get agitated. People talk about brain shocks, people get dizzy. Some people say there's water sloshing around in their head. So these are real problems when people come off these medications quickly. So if you were trying to change a medication, most people would start the new medication at a very low dose and then lower the older medication and give them both at the same time in what we call cross-titrate them. In general, you would not want to start one completely and then start a new one at the same time. I think just in general, people like to do it slowly each way, slowly decrease and then slowly increase the new one.
One of our viewers asked, but if you are functional and on the mend, do you have depressive episodes?
Can you have depressive episodes?
It's an episodic, even if you're on some type of improvement path, but still going to have episodes.
Well, yes, yeah, there could be, bumps in the road, there could be ups and downs. I mean, that's one of the challenges we have with depression. A lot of times we do see a drop in the depressive symptoms, in the number of symptoms people have, or the severity, but there's still some depression there. And so getting people to what we call remission, where they say, gee, I don't have any depression, I feel fine like I used to, that is a challenging thing to do. So a lot of people, unfortunately, tend to have some chronic symptoms that are still present over time.
Does depression run in the family, so to speak?
It certainly can. If you have an immediate family member, like a family, a parent or a sibling who's had significant depression, that increases your risk somewhat. It doesn't mean you'll get it. It's not what we would call a dominant gene. But in general, the more family members you have with a mood disorder, the more likely you are to have it. So definitely there are genetic factors. We haven't been able to find a simple gene here or there that explains it. It's very, very complicated. Yeah.
If you have a family member that was put on a medication following the death of a child, certainly justified depression and all that stuff, but it's been 5 years now, is there reason to go back and question, should she continue to take this medication? Do we need to evaluate? Or once you're on it in a situation like that and she's 83 years old, do you just say she seems to be doing okay? We're moving on.
Yeah, I mean, I think that's a question to ask.
Mm-hmm.
Most patients themselves tend to want to get off medicine if they can. So most of the patients I've encountered, when they're better from depression and it's been 2 or 3 years, they start asking, do I really need to take this?
Mm-hmm.
Now, other patients, their experience of depression was so painful and so overwhelming, they want to do anything they can to keep it from coming back. So it depends a little bit on the individual and what they want to do. If they're uncomfortable taking the medication, then it certainly sounds like that might be something to talk about with their provider. Mm-hmm. But if they're apprehensive about stopping it, it may be that keeping it is the better thing to do.
She hasn't raised any question. I'm the one that asked it. She didn't keep taking it.
No, it's a very reasonable question. I think especially after a death-relational stress like that. Yeah.
When it comes to anxieties, could the anxiety just be, certain type of deficiency that could be occurring?
Well, deficiency chemically or maybe nutritionally.
Yeah, magnesium. Could magnesium help?
Yes. I've had a lot of patients ask about magnesium, and there are a lot of people out there interested in taking it. I think it's worth a try. I haven't seen a lot of studies showing clear efficacy, and here's one of the problems. Doing a clinical trial where you have a group of people who take a treatment and a group of people who don't, is extremely expensive. If you're trying to get a new drug approved, you can expect to spend about $500 to $600 million to get a study that you can take to the FDA to try to get approved. And so if you're interested in an herb or a supplement or a mineral or a vitamin, those are not patented substances. Nobody's going to have the money to mount a really good scientific study of those drugs or those substances. So it's a little bit left up to the individual. You try to make sure it's not unsafe, and I don't think magnesium supplements are unsafe. So I think it's something where you read about it and try to make the best decision you can as to whether you might want to try that. I mean, I typically, we can talk about diet and depression in just a second, but I typically don't recommend excessive doses of vitamins. I mean, a vitamin D supplement is fine. A fish oil supplement has been shown to help with depression. And then just a B vitamin, you don't want to be deficient in any of the B vitamins or folate vitamins. Those are the main things that I think about. So look at your handout that has the picture of the brain and the gut, because this is a fascinating area of research that's been developing over the past 10 years. We have in our intestines a wide variety of organisms. And you might think, well, gee, that's not good. They shouldn't be there. But actually, it is good. They're doing things that are necessary for the healthy functioning, not just of your digestive process, but they are interacting with your bowel to release substances, chemicals, neurotransmitters into the bloodstream that then can affect the brain. And so researchers for several years now are looking at the relationship between the intestines functioning, or the gut microbiome as it's called, and mental functioning and psychiatric functioning. And they give the example here in an animal study, rats who had the onset of depressive behavior after they got a transplant of stool from patients with depression. And so you took bacteria from somebody that was depressed, you put it into a rat, and then they started to develop depressive behaviors. And then similarly, if they would take rats that were healthy and induce stress, then they would examine their bacteria in the gut, and it was reduced in terms of diversity and richness. So there's a lot of interest. You may have heard people talk about a leaky gut syndrome. That's the idea that there's inflammation or an unhealthy state in the intestine, and that can affect issues like fatigue, lethargy, brain fog, apathy, and loss of interest in things. So the key to improving your gut health is to eat the kinds of foods that are appropriate. You want to maximize fiber intake and improve your memory and overall mood. So high fiber foods would be beans, legumes, oats, nuts, dark chocolate, fruits and vegetables. Vitamin D is important. You don't necessarily have to take a supplement, but many people do. Egg yolks, tuna, salmon, orange juice, and milk have vitamin D. Protein contains nitrogen, which limits the number of bad bacteria. And so good sources would be eggs, milk, yogurt, lean beef, turkey, chicken, fish, broccoli, oats, and nuts. And then, of course, omega-3s. And you could take fish oil, or you could get it in your diet in terms of fatty fish like salmon, sardines, mackerel, or you could add flax seeds to your food, walnuts, and reduce, or you could look into probiotics, prebiotics, and postbiotics. So probiotics are foods with fermented cultures, so yogurt, or something I've tried recently, kefir, which is like a milky yogurt that you can drink. Kimchi, tempeh, fermented foods. They left out sauerkraut, that's a good one. Prebiotics are foods like chicory root, garlic, onion leeks that are good. And then postbiotics are active compounds when the gut permits. You can buy these in supplement form. So these are different techniques people are using to try to maintain the right mix of bacteria in organisms in the gut. And related to that is the benefit of an anti-inflammatory diet. I had a patient who was struggling with depression, and we talked yesterday, and she said, my depression's better, but I can't function. I get up, a physical therapist is coming, I'm supposed to walk back and forth on the porch of the house, but it's 90 feet long, and by the time I do it, I can barely stand up. So she's not really describing an emotional disturbance, it's severe fatigue. And as we talked more, it really sounded like she had what some people call fibromyalgia, or some people call chronic fatigue syndrome, or what's also being called encephalomyelitis. That's the term people are using now. And it's a poorly understood condition, but it does have to do with severe overwhelming fatigue. And people often reduce their activity level, and then they start feeling better, and then they go out and do something, and the next day it's almost like they're paralyzed again with just severe overwhelming fatigue. So that's thought to represent a hyperinflammatory state in the body, and there are many providers that approach this with an anti-inflammatory diet. So you want to avoid processed foods, snacky foods, processed cheeses, sugary beverages, fried foods, and just focus on whole foods, fresh fruit, and fresh vegetables, brown rice, turkey, chicken breast, eggs, again, fish such as salmon, tuna, herring, or mackerel, dried beans and peas, nuts, and seeds. And the Mediterranean diet and the DASH diet are two diets that incorporate these kinds of foods and are shown. The Mediterranean diet has been very helpful in reducing heart disease, and the DASH diet is good in reducing hypertension as well as overweight. So these things can also benefit your mental health and greatly. A lot of older patients, if you ask them if they're depressed, they don't really endorse sadness. What they're depressed about is they don't feel good. And that's often a sense of low energy, a sense of lack of initiative, lack of motivation, can't get started on things. They want to do things, and they remember, 5 or 10 years ago, I was up running all day long, and now I just don't feel like it. So, it's still an open question to me. Is that really a psychiatric condition, or is that one of these issues related to inflammation? And would they feel better, or could they feel better with dietary changes and moderate exercise? So that's my information, and any other questions that come up, I'd be glad to try to answer.
I got one regarding to calamine.
Yes.
Through research, how are they saying that this is effective for depression? Is it physiologically?
Yes.
How does it work on the brain? Does it depress that negative thoughts, those negative thoughts, so the good thoughts can come in? How does that work physiologically?
Well, in a way, it's thought to work on something called an NMDA receptor. It's thought to work on a different receptor than what the antidepressants work on. And it's supposed to work on what are called GABAergic neurons, which are inhibitory neurons. And when the drug is in place, somehow that changes the brain functioning in a way to reduce depressive symptoms, to reduce negativity, and in the dramatic cases, reduce suicidal thinking. So it's, again, through the same mechanisms of brain cells and receptor sites, but it's using a different set of receptors and cells than what the antidepressants typically use.
Okay.
And did you have a question, please?
Yeah, barring something that might be more biological or chemical, how would you describe kind of the role of isolation in older adults?
That's great. I did not mention that. Isolation in general is not good. There probably are some people who like being alone, but the evidence shows the more isolated and socially separated people are from others, the more likely they are to have both depression but also chronic health issues. So it's not good for your overall health. And that's one of the challenges in our society. We're so car-based and transportation-based. We're so spread out. It's very easy for people to be socially isolated from other people and to lose the connection person to person. That's so beneficial. Yes.
Do you have any information regarding the use of hemp or CBD oil?
Well, I don't. I mean, I've had some patients that have used it, and it's helped anxiety. So they told me that anecdotally. I haven't really seen, again, a study, in a journal testing it for depression specifically or anxiety. But many patients have found it helps them get to sleep at night. Again, the big challenge with CBD products, as well as all of the supplements and herbal products, is the purity and the quality of the product you're getting. They're not regulated by the FDA, so each company is out there, and you can put a product together, slap a label on it, and get some marketing together, and yet your manufacturing of it may be kind of sketchy. So that's the challenge. It's finding a product that's reliable in terms of its content. But I think from what I've seen, trying CBD oil or gummies is relatively safe, and some people get some benefit from that.
I have one more question. If you have a parent that is anywhere from 85 to 93, my question is, what symptoms exactly would you be looking for to give you an indication that they have depression? Say, for example, I have a mother-in-law who stays home all the time, no social contact with anybody, or she don't do anything, and she mopes and she complains about her personal illness. And then I have a mother who just sits around and look at TV all the time. When you try to make conversation, it's just like, nothing. So my thing is, what are the symptoms exactly are you looking for in an older person like that, as far as depression, that you will seek
Sure.
help?
Well, so typically, one of the issues that the aging experts have talked about with depression is that many older patients may not complain of depression, but they may complain of other things. So they may complain about their physical health, and at times it's a little hard to interpret because they may have good reason to complain. But if the negativity overwhelms anything else, if it makes them irritable, if it makes them stop going out to things they used to do, we often think that could be a form of depression, or depression could be contributing to it. Not sure quite what to say about your mother, where she's just quiet and wants to do one thing.
Yeah, but during the younger years, she will be real talkative and do different things.
Yeah.
I know we can go on and on with questions, but given the time, we have one more question and then.
Okay.
One thing I wanted to bring out is that in reference to and with your comment brought it to mind for me is that maybe assessing what other medications that person's taking for other symptoms, for other problems. Like, for example, my father takes Cymbalta, but it wasn't prescribed to him for depression, it was prescribed to him for neuropathy.
Right.
And so we started thinking about depression and didn't realize that could have been helping him along the way with the depression. That Cymbalta for the neuropathy could have been helping along the way. So he sits around, looks at TV a lot, but the doctor said there's no signs of depression or whatever. And I'm thinking maybe that Cymbalta may be helping that in some way.
Sure. All right, thank you.
I so hate to stop this conversation. Thank you so much, Dr. Jones. This has been fascinating. I have loved watching all the people in the room. They have been spellbound. And I know they learned a great deal that they'll take away with them and probably have to follow up on because there's so much information. Thank you for being here. And thank you again to our sponsor, Providence Place Senior Health and Housing. Our next program will be on Thursday, April 18th, here at Senior Resources of Guilford. We will meet at 11:30 a.m. for lunch, so RSVP please, so that we're ready for you. Our speaker will be Dennis Toman, who's the founding attorney with Elder Law Firm in Greensboro. He's going to help us understand and plan for the ways that we can manage and even protect our assets, both for ourselves and for our loved ones. The title of the program is Funding Resources as Our Loved Ones Need Care. Again, remember to register the program. You can go to the website acapcommunity.org. If you'd like to be notified of our upcoming programs on a regular basis, please like us on our Facebook page at ACAP Guilford. Thank you so much for being with us today. Thank you, Dr. Jones, and I look forward to seeing you all next month.
Thank you.